You're watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. Today's topic, and this is a special edition. We are talking about the latest advancements in pain management. We're talking to interventional pain management physician. He is the go-to person in Texas when you want to get out of pain and you want to do it holistically. We're talking about interventional pain management today with Dr. Garcia, Jacques. Dr. Garcia?
Randy, thank you so much for having me over. I'm very excited to tell you a little bit about how we practice in Houston, Texas.
Okay, good. Now you have a pretty large center. In fact, you have 3 centers. Is that
Correct.
right?
Yes, we have 3 different ways to practice pain medicine.
So you have 3 locations or 4 locations?
We have 5 locations.
5 locations.
Yes, 4 in Houston, 1 in Laredo, Texas, and hopefully we will continue to expand.
Okay, good. So who's the typical patient that you see in your practice?
The most common type of patient is 50-year-old who used to be very active. Something happened in their life that they're no longer able to do what they were doing before, right?
Okay.
And they want to become that normal person. So I always ask them, like, when was the last time you felt normal? So something happened to this patient, to this person. They no longer enjoy playing tennis, playing golf, playing baseball, or just simple going for a jog. Something changed their life and they are trying to avoid surgery. They want to become that pleasant person again, and they come to see me.
Okay. Now, you have 3 approaches, 3 levels, you say, of pain management.
Correct.
What are those?
So I learned during training and then a little bit after training. So I started with the typical interventional pain management, but I quickly realized that model doesn't fit everybody, right? There's patients who do not want to do a steroid-based approach or want to do more natural approach. So we offer acupuncture services in one of the locations.
Okay.
The alternative to steroids right now that's up and coming is regenerative medicine, stem cells, platelet-rich plasma. So that's what we can offer to those patients who want to avoid surgery and want to avoid steroids. And unfortunately, there's some very severe cases that the pain has changed their quality of life, their psychosocial circle. These patients have isolated themselves. They call themselves very appropriately the warriors of pain.
The warriors of pain.
Exactly.
Okay.
And they can get better with what we offer at iAche. I like the name because it identifies to them. They know they're in pain, but they want to be a better self. So we offer ketamine treatments, which will improve their pain symptoms.
Does it work, ketamine?
Absolutely, temporarily, but enough to help them have a better quality of life. We also offer in a place called iAche ketamine treatments along with psychosocial support.
Does ketamine work?
It does.
And who's a candidate?
When used appropriately. So what it does, it improves your hypersensitivity to pain. So pain changes the brain in a way that you become sensitized to it. The brain turns up the volume on any painful stimulus, and you feel that it's much more painful than you used to feel it before you were having this condition. And ketamine decreases that, and at the same time, it boosts your mood, so you feel better and you feel less pain. So patients are happier.
So is ketamine kind of like a transition drug where you're able to take it, get a little bit better mood, get feeling better as you're weaning off medications?
That's one of the options, or it can be a supportive treatment. Basically, it's an intermittent infusion. They come every 3 months, every 6 months, depending how long the treatment lasts them. Everybody's a little bit different. It's not a cure, but definitely helps them a lot.
Now, I invited you to the program today to specifically talk about 2 things: stem cells, which we'll talk at the second part of the show, and spinal cord stimulation. How does it work? What kind of problems does it treat? And what is it?
Well, spinal cord stimulation is, I call it a pacemaker for pain. It basically blocks the painful stimulus from going through the spinal cord up to the brain. It substitutes the painful signal from a very specific area of disease from getting to the brain. So it replaces it with, it used to be before a electricity feeling, a buzzing in the area where you're stimulating, but now with the high frequency stimulation, you don't even feel that, it just blocks the pain.
Okay, so somebody may have back pain. You put like a lead, like a wire in them, and it interferes with the signal to the brain.
Yes, it
so
blocks
now
it.
they can't feel the pain because the signal has been interrupted.
Correct.
Is that kind of how it works?
That's exactly how it works. We have to map the area where the pain is coming from. So sometimes during the trial phase, we get to test it out, actually. So we call it a trial phase. Patient is awake while we're implanting the lead, and we start stimulating to map where the pain is in relation to the spinal cord. So we are targeting the pain.
Okay, so if spinal cord stimulation works best for what?
Localized areas of pain. So it cannot be...
But nerve pain specifically?
No. I mean, it can be, well, a lot of it will be related to nerve, right? But it can be axial pain, the pain in the back that is coming from the bone itself or from the disc itself. As long as you map it properly, it will help that. But yeah, the most typical one has been for nerve pain.
Is the number one reason why people see you back pain? Is that like, or is it shoulder
I was thinking
or
about
knee?
that this morning. I think it's actually more neck pain. Neck pain followed by low back pain.
Does spinal cord stimulation work for that? This is because it's kind of a holistic approach, right?
Absolutely, yes.
It's no
one
medication.
of the tools in our armamentarium that we can use it for. But yeah, it works for neck pain. It works for the headache back here, the occipital headache coming from the neck. It helps that, and absolutely low back pain, and not to say any extremity pain.
So a patient goes to, let's start with the neck pain, and spinal cord stimulation. Who's a candidate, and how do you identify if they would be a candidate, and how soon does it start working?
Yeah, so these patients, by the time they come see me, they have tried a lot of things. Physical therapy for several weeks, medications, they've seen the surgeon, they want to avoid surgery, or they're not a candidate for surgery, or the surgeon said, like, the pain may or may not go away, we're not sure. So by then, it's easy to identify. Let's just try it out. Let's see if by putting a little cable close to your spinal cord, safely, obviously, we can block the pain.
So it's like a little tiny, like a needle?
Yeah, it goes through a needle.
So they're numbed up a little bit?
They are numb and anesthetized during, so they can be totally asleep if they want to be.
And you put this electronic stimulation on the nerve? You're pointing it at the nerve or
Correct.
the area?
You're pointing at exactly what you said. You point it at the nerve. You don't put it in the nerve, but you are pointing the electrodes, the ones that produce the electricity, pointed at the nerve, so that we can replace those signals of pain with the stimulation. So to place this lead, like with the spinal cord stimulation lead, you use a needle for the trial phase. You pass the needle to the epidural space, which is an anatomical space that we get there by X-ray guidance for the needle placement.
Okay.
And then we just advance the lead and start mapping the spinal cord sensations. Where is the pain coming from? And the patient was numb and asleep during the process. We wake them up for the testing so they can tell us, I feel stimulation in my arm, I feel in my head. Oh, like that's where I feel the pain. Now we hit the jackpot, we'll leave the lead there, and the patient gets to try it for 5 days, 10 days.
Okay, so it works. They could feel pain relief in certain instances while they're there getting a trial.
Not the pain relief there. They feel it in recovery. So just as soon as they actually go to recovery, but there we're actually stimulating so that we can know where the electricity will reflect in their body.
Okay, so they go home with their neck pain with this lead temporarily. Is it like taped? Or is it implanted?
It's taped at this point.
Okay.
This is a trial phase. So we have the patient have the generator for the lead is going to be outside, taped to the body, and we secure the lead very well to their skin, and they go home. The downside is they cannot shower, but they can do sponge baths, and they get to enjoy, see how it feels. And a lot of patients will say, this is changing my life. So, and some of these patients go home and they stop having pain. There was this patient who used to be very active, didn't want to have surgery, wasn't a great candidate for surgery, had this done, was back in the workforce. I think he worked for AT&T and used to be on ladders and climbing. He could not do that. After the stimulator was trialed and permanently placed, he was able to return to work.
Okay, so they go home with it for like 10 days or something like that?
Maximum almost 10 days.
Then they come back, and if it works, you implant one that's a little bit more permanent.
Exactly.
How long could that last?
The battery will last 10 to 15 years with the newer models, sometimes a little bit less depending on the intensity of how much electricity they're using. But yeah, and then at the end of that phase, you just take the battery out, replace it with a new one.
So these are people that were able to avoid surgery and or drugs?
Yes,
heavy drugs.
Exactly.
So is it like a holistic approach? I mean, what do you guys call this in your world? Spinal cord stimulation.
I call it part of the integrative model. So we
integrative model.
Integrative model,
okay,
exactly.
Okay.
So we look at the person as a full, and we try to be their best with minimum side effects. So imagine this is not a drug that will give you side effects or kidney problems or liver problems. This is safe, and you can take it out, right?
Now, with the neck pain, what's causing it? Degeneration of the discs, I mean, what's happening
That's
usually?
one of them, yes. So it could be discogenic pain, so the disc become diseased and starts generating pain when it shouldn't, or arthritis of the neck will cause this. A disc bulging, disc herniation on the neck, compressing on the nerve will also cause the neck pain.
So by injecting this, if you're confusing the signal, they'll still continue to have problems as far as the neck breaking down?
Correct. We are not stopping the degeneration or the progression of the disease.
Just a signal to the brain that it hurts.
Exactly.
Interesting. I mean, it sounds like everybody would do this.
Yes,
You know,
think so.
and we talked in the green room because a lot of people would be candidates for back pain too. But sometimes you're telling them to do it and they're resistant. Why do you think that is?
I think it's a fear of something new. Like, are you going to put a battery on me? Am I going to be plugged to the wall? It's just the
Because it sounds like surgery.
uncertainty.
Is it the surgery that they're afraid of?
Probably, maybe that part. But you get to try it. You don't need surgery to try it. And if you try it and it changes your life, then a probably 5 to 10 millimeter incision will probably be worth it.
Okay. Now, for back, how does it work? How does spinal cord stimulation work for back?
Same process. We map the pain. Where's the pain coming from? So for the neck, we put it in the neck. For the low back, we'll put a little bit in the mid back. The lead, this device where the electricity is going to.
Okay, and for some people, this is like a miracle?
Absolutely, yes. So let me tell you about a patient of mine, Freddie. So
Okay.
he's in his late 20s, had a catastrophic injury in a steel factory, I think, and he requires surgery. So they have to reconstruct his L5. During the accident or during the surgery, something happened to one of the nerves and he developed foot drop, but also, which means he cannot walk well, he cannot lift the foot, but he also had lancinating, very severe pain down his left leg. He basically was depressed, he didn't want to do anything, and he felt like he was just a charge to his family, his friends. He isolated himself. Anyways, he comes to me, let's try this. He was very, very hesitant. He actually went home angry at me and then came back a month later, gets to try it. He's the
spinal
happiest
cord
person.
stimulation
The
we're
spinal
talking
cord
about.
stimulation, yes.
Okay.
So we stop his pain. His foot, he's still confident that he will regain the strength of his foot. I tried to counsel him that maybe not. Well, he's working again in a desk job, no longer doing what he was doing before, but he actually is feeling like he's productive again. So Fred is one of the patients I love the most because he was angry at me for offering it, and now he's very grateful.
Now, we talked about this in the green room that oftentimes the interventional pain guy is the last person they see. They see the neurologist, they see the spine surgeon, and then by the time they get to you guys, they're in bad shape oftentimes. Do people need a referral to see an interventional pain doc?
Most of the time they don't.
They could call you directly.
Yes.
And you take Medicare, right?
Yes, we do.
You take all the insurances.
Correct.
Just about. And so you were an anesthesiologist trained, board certified.
Board certified.
So you keep them out of pain while they're asleep, and now you're keeping them out of pain while they're awake.
Exactly. Yeah, that's a way to summarize what I do.
And are there a lot of people, give me your opinion, are there a lot of people, like tens of thousands, hundreds of thousands in the state of Texas that are in pain that don't have to be?
Yeah,
You tell
yes,
me.
a lot of them are in pain they don't have to be. There's a statistic that show that most people will develop chronic pain. 70% of people along their lifetime will develop chronic pain. So imagine that these patients don't need to be in pain. The other thing that worries me is, like, even if you have a little pain, don't ignore it, because it will continue to progress. If you ignore it, it will just get worse. And that's a perfect time to actually come see an interventional pain specialist, because we don't only will give you a medication to stop the pain signal, to block it, we will coach you on how to stop the progression, how to be more active, better.
Because you're not just thinking surgery, obviously.
No, absolutely
And drugs.
not. No.
Would you say that as an interventionalist, you're trying to avoid drugs and surgery whenever possible? Is that fair to say?
That's what I do, yes.
Okay. So your whole AIC system, your centers, are based on that.
Yes. So we want to change behaviors that have promoted the injury, and we want to treat the pain, but also prevent the progression of any other conditions that we can identify.
Have you had patients with back pain, neck pain that were scheduled for surgery, and with some of the interventional techniques you're doing, they avoided surgery?
Yes, I tell my patients, my job that I'm doing for you is avoid you from going to needing the surgery.
Okay. And now you get referrals from the neurologists, the orthopedic surgeons, the spine surgeons. You work together?
Yeah, absolutely. So a patient that has weakness, for example, developed an injury that is getting weaker and weaker, I will do a disservice if that patient doesn't go and see the surgeon, because they will regain their function quicker and without the nerve damage. So I work alongside with them as well. They send me patients that they don't think they didn't need surgery, and then we compete for some of the patients as well, right? Sure. But I work closely with chiropractors, physical therapists, primary care doctors, orthopedic surgeons, neurologists, psychologists.
Now, I'm no expert on this topic, but I do live on a block where everybody's in pain. They're all 70 plus guys. And knowing you were going to come on the show, I said, have you ever heard of an interventional pain management physician? None of them in their lives have heard of this specialty. So I guess you guys are like facing a bit of an identity crisis, right? They don't know that they could ask for an interventional pain doc.
Exactly. It's a shame because, like you were saying, we can avoid people from having medications. Some of them will have horrible side effects, addiction, death. I think 50 people a day die in the United States from prescription drug overdose, mostly from opioids. So we can help them avoid that. But at the same time, the pain crisis or the pain pill crisis that happened in the United States created kind of these sense around people that the pain doctor will only give you pills. And that's not true. We actually avoid that.
And we're short on time. And I want to talk to you about stem cells. So there's a big movement, apparently, in the world of pain management where there's centers where they're just injecting things into shoulders, in knees, and backs, and discs. And but they're not really stem cells, you say, in many cases. But the patients think they are. So could you kind of help us understand what are real stem cells? Because you're involved with this Regenix, which is a large organization that keeps the data. So tell me about stem cells.
Kind of hitting, I am hugely passionate about this topic, so you'll have to stop me probably at some point. I think it's the future of pain medicine and orthopedics. The stem cell will revolutionize and minimize the amount of surgeries that we're doing on people. But anyways, about your question, so you cannot buy stem cells that are powder that you inject fluid to reconstitute it, right? So it just doesn't make sense that there's cells in powder and you just inject the liquid.
Is that being done?
That's being done, and it's being sold as this is a stem cells. And it's like representatives from the pharmaceutical company come to see me and they say, yeah, this is what we do for stem cells. Like, yeah, no, that's not stem cell. How not? Well, why not? Like, it's in a powder. You cannot have cells in a powder.
Are these from babies? Anyways. I mean, are from like?
Yeah, like I mean, not from babies, but amniotic sac.
Okay.
Umbilical cord derivatives. Right now, actually, just recently, the FDA basically said, stop it. This needs to be researched for safety. So whoever's offering you stem cells in the United States is probably doing so illegally, if I may be that abrupt. But so representatives from a pharmaceutical company come to see me and they try to sell me stem cells in powder. I said, how can that be effective? There's no stem cells there. They may be able to recruit some growth factors, but we don't know if it's actually doing it or so. So I actually never did it because I didn't think there were any cells there, but the data out there is wishy-washy, right? Sometimes it works, sometimes it doesn't, and I don't like that.
Okay. So let's talk about the different levels of what you're injecting. Let's start with shoulders, because you told me on the phone you love shoulders.
I love shoulders.
Works great for shoulders.
Yes.
So give me some of the treatment options for people with bad shoulders, rotator cuff problems.
Yeah, so I recently treated an 18-year-old surfer. He could not surf because his shoulders were in pain. He does jiu-jitsu, so probably chronic injuries. We did an MRI, minor tears, inflammation around the rotator cuff. So we only did prolotherapy on him. Prolotherapy is dextrose, so basically a purified form of sugar that we can inject safely into the tendons and the ligaments. It creates an inflammatory response, and data is phenomenal. 40% thicker ligaments 6 weeks after prolotherapy, as long as there's not a major damage to that joint.
And the shoulder's better.
And the shoulder's better.
And what about like 60-year-olds, 70-year-olds?
Same thing. So let's assume there's a little bit more injury. There's some tears or full tears. We can inject platelet-rich plasma. So we basically do a blood draw, super spin the blood and recruit a lot of the platelets. The platelets they're the ones that plug when you're bleeding, right? So that's the function of the platelet, stop you from bleeding. How does it do that? It generates the plug, and then it helps with the regeneration of the blood vessel, of the skin, the scarring, and all that, right? It starts the process. It can do that with your tissues. We break them down, or they break down themselves, and they start recruiting the growth factors.
So you inject, let's say, this PRP, which is their own blood you spun, and you say at a high intensity.
Very high concentration.
High concentration.
So with Regenix, we can get up to 40 times concentration of your regular blood, the amount of platelets that we can concentrate. The regular bedside spinner to take 10 minutes, maybe 7 times. But we can do it up to 40 times.
And there's a lot of these centers, I guess, opening up. Like you mentioned Prolotherapy and Prp, and you say you're doing it differently.
Absolutely.
How so?
So I love that they're opening up. 2 things, because they will help us see that we're a lot better. Okay. And the other one is because it helps educate the patients, the people out there, that this exists. But recently I treated a lady, she came in and already spent $6,000 on PRP, didn't help me. I was like, how do they inject?
These PRP injections?
PRP injections, okay. For the knee.
Okay.
But so they took blood on me, 10 minutes later they came back and they injected in the knee. I was like, did they ask you where it hurt? Like, no, they just went into the knee. So did they do an ultrasound evaluation? So anyways, we're different because on this lady, I use ultrasound. I show her, look at this ligament, how lax it is, see how it moves, your knee joint.
So you're looking at imaging?
All the time,
and so
for diagnosis and for treatment.
Okay. So before you inject?
Before we inject, we do a diagnostic ultrasound on any joint. And then we help stabilize the joint, and then also treat the joint when it has disease. But yeah, we use ultrasound-guided techniques, X-ray-guided techniques live with the patient right there. So she was very surprised that I was doing the imaging. She didn't know that existed.
How does it work for her?
She's doing good. She came back. So we treated the knee that day. She came back for her hip and her neck. So I think it did very well for her knee.
Did that very well. So let's talk about shoulders, because one of the things, now let's talk about the other types of stem cells, which are from the marrow. What's involved in that? And how predictable is it, and why is it so good on shoulders?
It basically, when the injury is a little bit more severe, so let's say you have a 70% tear of one of the rotator cuff muscles, then the PRP is probably not enough. You need a lot more potency. So we actually have to draw bone marrow from the hip, painless process. You can be sedated, it can be done under local anesthesia. So it's not a big deal. Okay. When we extract the bone marrow has stem cells, mesenchymal stem cells that they can reproduce into a different type of cell, or they can actually recruit the cells that's needed in the injured area. But it helps bring that rotator cuff muscle together. So let's say it's torn, and it just helps connect it again.
So your body kind of regenerates itself in a way?
Yeah, I mean that's every time you cut yourself, it regenerates. It's what the body's supposed to do. We're just giving it a little push to do it a lot faster. So recovery is a lot quicker than surgery.
And this is cash out of pocket stuff, right?
Yes.
When it comes to stem cells.
Yes, it's so new that the insurance companies have not caught up to it, and they're going to be 10 years behind science usually. So eventually it will become coverage, but not at the moment.
Behind your back, I talked to an orthopedic guy, and he said, Randy, I don't know, the shoulder, it's not like a knee that only moves one way. Shoulder is very complex. I don't think stem cells work in the shoulders. So you have the data to back up what you're saying?
Absolutely. So Regenix, which I'm a member of the network, has been going on for at least 15 years. Every patient I see through this process gets a registry, and they at home report the data on the computer. So we have more than 40,000 cases, all the joints, all the spine, everything. The shoulder is the one that gets the best results, knees. It's fantastic. And imagine, more than 40,000 patients telling how they did. Not everybody does well, but we can titrate and change things so that those patients that didn't respond, what's going on? How can we do better?
The high rollers, or the professional sports athletes, are they doing these kind of things?
Yes. So in order for me to get into a network, I had to go to Denver to train. Their walls are covered by NFL players, baseball players that are signing off. Thank you, doctors, for getting me back to the sports. Yeah, NFL, MLB, dancers for Disney. It was amazing. It was celebrities left and right. It was a joy.
So the back pain. Let's talk about back pain. The disc. But if you have a degeneration in the disc, if you have a problem with the disc, what kind of shrink with age? And
Yeah,
then you end
it
up
loses
pushing on
water
the
content.
Then you push on the nerve, and that causes the pain.
Exactly.
So how is stem cells going to help that?
So we can actually inject into the disc. That's not everybody qualifies, but when that's happening, and if we tried everything else, it didn't work, then we actually can inject stem cells, PRP or bone marrow, into the disc.
Do they grow? Do they grow?
Exactly. Yeah. You're
Really?
putting stuff in there that was not no longer there, so it bulges back up and pulls the extruded area back from the nerve.
Interesting. Do you use stem cells in your practice? We're talking about from marrow in their own body. So these are real stem cells, not the PRP or prolotherapy. Do you have people that their pain is just gone forever?
Yeah. One of my patients just applied for a job at the office.
Okay.
She's 18, wanted to be a pilot, got into a car accident, water polo player, I believe, and she could no longer train because she was in so much pain. MRI was clean, we tried steroids. She's an 18-year-old, I cannot keep injecting steroids. She actually responded to steroids, but only for 6 weeks. Anyways, long story short, she gets PRP. Came to apply for a job and now wants to become a nurse. She's like, this is life-changing. I want to help you do this and promote it. It's amazing. She may start very soon.
So a person with back pain, neck pain, I guess your role when they go there on the consult with imaging is to figure out what treatment is best for them.
Exactly.
Without drugs.
Without drugs.
Okay.
With minimum amount of drugs. I'm not totally opposed to medication management, but it's one of the tools we will employ, not the only tool.
Okay, and there are people, and we talked about this in the green room, that are living on these like ibuprofen or Aleve or whatever, and they don't have to be.
Yeah, no, most of my patients tell me I'm off the medication, I'm just taking an Aleve whenever I need it, Aleve, Tylenol, etc. But yeah, they used to live off of it and be able to function because of it, and now they're only using it sporadically, sleeping better, feeling better, doing what they used to like.
Final message to the patient watching this: back pain, neck pain, shoulder, knee pain, they have pain. And they think they've tried everything. They've never been to an interventional pain doctor, an integrative, holistic pain physician. But let's say they're skeptical. They've heard what you're saying. They're skeptical. What do you say to them?
Try it. If you tried everything else, why not try calling us? Just come see us and...
I mean, insurance covers it.
Exactly.
I mean, the only thing I guess it's not covering is Medicaid. Is
yeah,
that right?
Medicaid I'm not enrolled with in the office.
Because it's very difficult to get paid, is that correct?
Yeah, it's very difficult to get paid, and when they pay, it's not...
But Medicare, so everybody over 65...
They can see me, yes. They will get covered, and I can give them my opinion.
Now, you have a bunch of centers, right?
Yes.
Do they ever get to see you, or they'll see one of your doctors that you work with?
I try to see the new patients with me, but we're getting busier, so the other doctors are... But I train them, and they can always be referred to me directly.
Dr. Garcia, Jacques, I want to thank you for coming on the show. Good stuff.
Thank you for inviting me. It was a pleasure.
Could they go to the website, make an appointment there, or do they call live?
They can call, they can send us an email, contact us through the web. We're there. We're going to reply very quickly.
Okay, good. I want to thank you for coming on the show. You've been watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. For now, I wish you good health.
Thanks for watching the Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.